For most of a woman's reproductive life, her cardiovascular system has built-in protection. Arteries are flexible, blood pressure remains stable, and lipid profiles are balanced. Yet peer-reviewed clinical literature documents a sudden, severe shift. Cardiovascular disease risk increases fourfold in women following their final menstrual period. This sharp acceleration does not take place over decades. The entire surge in risk occurs strictly within the first 10 years of postmenopause. A common misconception attributes this decline entirely to the passage of time. However, the speed and severity of this fourfold increase significantly outpaces what standard age-related decline alone would produce. These measurements identify a distinct physiological shift. The loss of ovarian function initiates a decade-long period of rapid vascular change, driven by specific hormonal fluctuations. To understand this risk window, we have to separate chronological aging from ovarian aging. Chronological age tracks the calendar. Ovarian age tracks the function of the ovaries and their hormonal output, which directly governs vascular health. Comparing women at the same chronological age, the premenopausal profile has regulated lipids. The postmenopausal profile reveals elevated LDL and triglycerides, with reduced HDL. These adverse cardiometabolic changes start early. Cholesterol spikes consistently begin 3 years prior to the final menstrual period. The transition period itself initiates the damage. The cardiovascular timeline is already accelerating while a woman is still menstruating. Alongside these lipid shifts, the blood vessels experience measurable hemodynamic changes. Blood pressure climbs as the vessels lose their estrogen-supported elasticity. Risk assessments that treat a 50-year-old premenopausal woman the same as a 50-year-old postmenopausal woman ignore the most dominant physiological variable in female cardiology. Endogenous estradiol acts as the master regulator of female vascular health. It dictates the systemic mechanisms that keep blood vessels clear and functional. At a baseline metabolic level, estradiol upregulates LDL receptors in the liver. These receptors actively pull LDL cholesterol out of the bloodstream, preventing it from accumulating in places where it can do damage. When estrogen drops during perimenopause, that clearing mechanism falters. The smooth, protected fluid dynamics of the artery begin to degrade. Without sufficient estradiol, LDL receptor activity severely decreases. The liver simply stops clearing cholesterol at the necessary rate. This line graph tracks the timeline of the atherogenic shift. As LDL clearance halts, small, dense LDL particles and triglycerides rise steeply precisely during the perimenopausal window. Concurrently, protective HDL cholesterol falls, creating a widening gap that favors arterial plaque formation. Compounding this issue, declining estrogen causes body fat to redistribute from peripheral areas to the abdomen. This visceral fat accumulation independently drives insulin resistance and systemic inflammation. The sudden loss of estradiol removes the liver's clearing mechanism while simultaneously increasing inflammation. This creates a self-accelerating cycle of lipid accumulation that damages vessels long before a patient reports clinical symptoms. Moving from the bloodstream to the cellular structure of the artery itself reveals how this chemical shift physically degrades the endothelial lining. Healthy arteries rely on nitric oxide to widen and relax. Endogenous estradiol promotes this nitric oxide production. When estradiol declines, that chemical signal stops. Deprived of nitric oxide, blood vessels lose their flexibility. This decreased vasodilation creates a stiffer container for the blood, forcing blood pressure upward and forcing the heart to work harder. Simultaneously, the antioxidant systems within the arterial wall begin to fail. Inflammatory cytokines, previously suppressed by estrogen, release unchecked into the vessel tissues. High circulating LDL particles now meet a rigid, inflamed endothelium. They embed themselves into the compromised tissue, accelerating the progression of subclinical carotid plaque. Endothelial dysfunction translates a systemic hormonal deficit into irreversible physical damage. Counteracting this specific vascular degradation requires treating the cellular deficits of ovarian aging rather than relying on standard protocols designed for chronological age. This matrix contrasts standard clinical tracking with proactive, targeted natural interventions that address the exact biological mechanisms failing during menopause. Omega-3 fatty acids, specifically DHA, are a direct countermeasure to the menopausal lipid shift. DHA physically suppresses inflammatory pathways along the endothelium, mitigating the cytokine release that allows plaque to form. Furthermore, DHA directly addresses rising serum triglycerides, clearing the bloodstream of atherogenic particles. For structural arterial support, highly bioavailable forms of magnesium, like magnesium glycinate, offer critical utility. Magnesium regulates the electrical activity of the heart muscle while maintaining the chemical pathways required for arterial vasodilation. It restores the relaxation response lost when estrogen declines. DHA and magnesium glycinate are precise biochemical tools. They physically interact with the lipid receptors and endothelial walls to counteract the specific cellular deficits triggered by the loss of estradiol. Supporting the lipid profile and maintaining arterial flexibility allows the cardiovascular system to operate safely, even without endogenous estrogen. The 2020 American Heart Association scientific statement evaluated all longitudinal data on this transition and established a precise clinical mandate for when to act. This timeline identifies the highest leverage clinical window for intervention, the late perimenopausal phase. Waiting until post-menopause to address lipid shifts and rising blood pressure allows years of unmitigated stress on the arterial walls. By the time a patient is officially post-menopausal, structural entrenchment has often occurred. Arterial stiffness and plaque formation transition from preventable metabolic shifts into permanent physical features of the heart. Deploying targeted natural compounds to address inflammation and lipid clearance during perimenopause intercepts the four-fold risk multiplier entirely. It secures long-term cardiovascular viability exactly when the body's natural protection drops.